So this is the second and last lecture for Unit 2. Unit 2 is solely focused on assessment. So we have made our way up through the oral MEC kind of cranial nerve assessment. And this is again going to be more of an informal piece with respect to, we'll talk about a little bit later in today's lecture, is that the formal assessments out that are published with regard to dysarthria will not provide us all the information that we need in order to provide an accurate diagnosis, understanding stimulability, in order for us to meet our patients' needs, in order to provide appropriate therapeutic goals and interventions. So um, you watched last class period the oral MAC assessment, and we're going to move forward. We're going to start talking about some of those specific domain areas, phonation, respiration, resonance, etc. And something that we're going to focus on within this lecture is the stimulability piece. I'm going to go over really what that means for our patients and for us, and then kind of walk you through the resources that I've provided you on Blackboard to help support you in one, doing your Unit 2 project, but two, to be a clinician and being able to assess stimulability with real patients. That's really this first lecture because we have, again, Unit 2 has five PowerPoints. We're on the third one. We're going to wrap up the third PowerPoint. We're going to then talk about assessments, standardized assessments for dysarthria. That'll be quite brief. And then we're going to then talk about intelligibility and what that really means for real patients, and then we'll kind of move forward from there. So the last lecture we watched, it was that oral MEC cranial nerve assessment, and part of that is assessing phonation. So part of every kind of motor speech assessment, dysarthria assessment, is going to include having your patient have a prolonged ah. Prolonged ah, just saying, okay, I want you to say ah for as long as you can. So just ah, holding that out with the patient's normal habitual pitch. You're not going to have them necessarily elevate or raise their pitch or lower the pitch just for prolonged ah. It's just their habitual natural pitch. This is going to help provide some informal information about breath support and also about vocal quality. So I have some norms there, and there's quite a bit of variability. Just like in voice, there's quite a bit of variability with some of these norms for maximum phonation time, habitual pitch, etc. The same is true for motor speech and dysarthria. So normal elderly males, we're talking about prolonged we're kind of thinking about that 13 seconds might be kind of within normal limits, but the standard deviation of 6 means plus or minus 6, which is quite a bit of variability in seconds. But if you think about Duffy, he actually just provides more of a simple, just kind of more simple working definition of what would be normal for prolonged and said anywhere between 8 or 9 seconds is kind of within the normal limits. Anytime we're taking objective data, we have to provide context to that data. So we'll be talking about respiration in just a second and talking about those informal means, but something we're going to do for phonation is a prolonged and getting information about vocal quality, etc. And in addition, we're doing a prolonged or maximum phonation time for respiration and getting some data, how long can that person hold that? But we have to provide context with regards to, is this supporting communication? So we'll talk about maximum phonation time and an extended vowel prolongation in just a second with regards to respiration. Fine. Okay, so let's move forward just a little bit. Again, that's from last lecture. We talked about that. I'm just kind of transitioning from where we left off last lecture. Okay, so here we go. Phonation, we've talked about that. Fine. So we're going to spend a little bit of time talking about the other domain area of respiration. And with respiration, we want to just look at natural or normal breathing at rest. So when we're doing that, we want to not only look at the rise and fall of the chest or lack thereof, which hopefully we'll talk about movement, excessive movement, and how that's atypical, but we also want to look at just general posture. So when that patient is communicating, most of our patients are going to be, for an evaluation, are going to be seated or in a wheelchair, but we want to kind of just look at their general posture, at rest with breathing, during communication or phonation. So is the patient, do they have a hemiplegia? Are they drooped to one, are they slouching to one side? Do they have the diaphragmatic support and posture to be able to kind of sit upright during communication tasks? Those are just things we kind of want to take in informally, because that might impact what we can or cannot do in therapy with regards to kind of breath support. Things we want to look at is just normal rate of breathing. So there are different, shocking, there's different norms out there in the literature, but when we're talking about just like resting breathing, wakeful breathing, so someone who's just breathing, who's awake, who are the patients that we'll be seeing for dysarthria therapy, we're looking at some of those norms. I said 16 to 18 cycles per minute, but anywhere between like 16 and maybe even 22 breaths per minute, so rise and fall of the chest 22 times, is pretty kind of typical within the normal range. That's kind of normal. So those are things we want to take into effect. Typically, when we're talking about the patient populations we serve for dysarthria, and we're talking about more medically complex patients, they cycles per second, how many breaths per minute, cycles per minute becomes a little bit more important if we're talking about someone who has like a paralysis, who is a who might have a neurodegenerative population where breathing is inefficient. So their breaths per minute are increased, their respiratory rate is increased to try and make up for that, trying to compensate for that inadequate breath support. So if you're in the hospital, you're looking someone who may have had a spinal cord injury, who has had paralysis to the phrenic nerve for the diaphragm, or again, neurodegenerative populations, they might have a respiratory rate in the 30s, which is inefficient for kind of appropriate maybe phrasing or breath support for conversation, but that might be their new norm. So just keep in consideration that we're going to look for normal rate of breathing with our patients. Then we're going to look for if there's any effortful or labored breathing. So some signs or symptoms might be excessive shoulder movement or clavicular breathing. So we're seeing, instead of that adequate kind of diaphragmatic kind of like breath, that we're going to see movement in like the chest area, or the diaphragm is where we want to see that movement. We might see someone who's moving their shoulders kind of so excessively to try and compensate for that. And we can see that that's not just maybe habitual, but from like a neurodegenerative population, they might be trying to compensate. So we want to look at signs or symptoms of effortful or atypical breathing. So we might see excessive neck extension, flaring of like the nares. That's fine. Things we might see, but not all patients are going to have some of these red flags. So we're looking for red flags: rapid or shallow breathing, again, excessive shoulder movement or clavicular breathing. The clavicle is kind of this area here of the shoulders up is moving versus kind of that diaphragm. All right, so I put this in here because it's in all of the motor speech literature, this picture, so we'll get to that in just a second. Something that's really functional and very easy to do at bedside or outpatient or any kind of medical setting is just simply asking a patient to count 1 to 20. I think it's a really nice, easy task. And there's a lot of subjective information that we can get just by having patients count, just counting. So things we're going to kind of look for with this, we're going to kind of perceptually listen for vocal intensity. Are they too loud? Are they too soft? We're going to kind of see if the patient's kind of running out of air even when they're counting 1 through 20. Something to consider in general, whether it's conversational speech or just this kind of structured, really simple task of counting 1 to 20, is the patient starting to speak? Is phonation beginning truly at the beginning of expiration? So we want patients for breath support and efficiency of using that airflow to begin phonation as soon as they start to expel air. So something we might see in some patient populations is that we might see exhalation or expiration happen, and then as that's happening, they're starting phonation a few seconds into that, which is inefficient because they've already used a lot of the reserve for air. All right, so we're just in general maybe we're going to look at the person at rest, looking at their posture, looking for any signs or symptoms of like atypical breath support, posture, red flags for shortness of breath or excessive distress with breathing, respiratory rate, etc. And then something I do for all patients, and the literature just supports this really easy task, is just having patients count 1 to 20. With that, again, although I'm saying we're looking at respiration, we're looking at kind of vocal intensity. We can also get information about phonation and vocal quality. So although some of these tasks might be under the domain area of respiration or phonation, etc., we know that with dysarthria, it's typically a multi-system approach, and speaking requires all of our systems, respiration, phonation, resonance, articulation, and prosody, in order to be efficient. So when you're thinking of your Unit 2 project, you can use one task and and then kind of list some things you're eliciting from it. So you can use the counting task 1 to 20 and say you're getting some information about respiration and kind of listing those things you're looking for and maybe taking data on. But there's another task where we can get some information about phonation as well. We can get some information, of course, from any task about articulation, just so trying to kind of put the pieces together in this. All right. Something you might want to do in general, again, counting 1 to 20, is just kind of seeing if the patient can kind of shift their variability in vocal intensity. So can they say ah? So again, prolonged ah, we're going to get some information about respiration with that. Absolutely. So we talk about, where was it? Here we go. Oops. I'm talking about with prolonged out breath support and kind of understanding vocal quality, etc. But we can also just have the patient also see if they can kind of shift, here we go, can shift and change their vocal intensity from soft to loud, loud to soft. That takes quite a bit of coordination at the level of the vocal folds, in addition to having a intact respiratory system to kind of shape that together, because when we're talking about vocal intensity, we have to have appropriate control of respiration and airflow, but also at the level of the vocal folds. And I'm going to leave it at that because we talk about that quite a bit in voice. And then I put this picture in here. Again, you're going to see it in your motor speech book. The water glass manometry informal assessment. Again, it's in all the books. To be completely frank with you, I've never used this with any patient in any setting. I've never had the time or resources or found really the value necessarily in doing this. Again, we're talking about respiration, and I think we've got some really nice perceptual pieces. We can do prolonged ah, we can do counting, we can look at breaths per minute, that cycle. We can get some general ideas, because the goal is the patient's respiratory system efficient enough to have connected speech that can be heard by others with appropriate phrasing? That's kind of the goal, right? So we can have all of this objective data on vital capacity and all of this numeric value, which is important. But the gist is the respiratory system efficient enough for that patient to have conversation, communicate with others, that the other person can hear them, and are they using their system appropriately, or can they use, or to the best of their ability, whatever that etiology is, the underlying one. So for me as a clinician, I didn't use the water glass manometry, and here's the directions on how to do that. I didn't get a straw, I didn't tape it to water, and I've never had my patients blow bubbles and see if they can hold that stream of bubbles for 5 seconds, because I feel like I can get all of that kind of general information about breath support through other ways than having a patient blow bubbles in water. But feel free, it's out there. There's evidence to support using this in your assessment. It's just not something I have used. So I did put that in there for you. If you want to put that in your assessment, of course you can. It's just not a task that I have ever used with a patient. Okay, here we go. So now we're going to move through. We did the cranial nerve oral mech assessment last lecture. You watched that video. It's a little old. It's an oldie but a goodie. We talked a little bit about phonation. We talked a little bit about respiration and breath support. I want to spend just a little bit of time talking about those other areas of our assessment. I know this is a little bit of a review for you, but let's talk through it. So let's talk through assessing movement during a few different tasks. And we're going to talk about diadocal kinetic rates. So we're going to talk through AMRs, SMRs, getting some information from repeating phrases and words, engaging in conversation, of course. So again, we talked about respiration, phonation, respiration. Now we're talking about articulation. So articulation, I know we probably have a really good lens of what that looks like for pediatric populations and giving like the Goldman Fristow, giving that assessment and then looking at specific phonemic distortions or error patterns and initial medial final position with certain clusters, etc. That's from like a developmental perspective, whole nother class, speech sound disorders, etc. Well, when we're talking about acquired disorders, we're talking about motor speech disorders, most of our patients with dysarthria are going to have some deficits in articulation, more than likely, and they're going to have imprecise articulation. And this is not a habitual thing. This isn't a developmental thing. It's acquired because of some domain area that's kind of producing this atypical production. So we take our articulation information through a lot of informal assessments. So we're going to take information from, engaging in conversation. We might have some repeated words or phrases. And then we get some information from AMRs and SMRs. But in the real world with adults with motor speech, we are not going to give the Goldman Bristow because one, it's a pediatric assessment and not norm for that. But two, you're not going to have time in a medical setting to give a 15 to 20 minute articulation assessment at the word level because it's probably not super functional for an adult at conversational level trying to meet their needs to improve their quality of life and activities of daily living at the word level. So we typically will take information about articulation through all of our other informal assessments. I will say though, working in outpatient and working with some individuals who have had extended therapy and have more clinically more mild deficits, maybe UUMN, there might be specific clusters or phonemes that might be a little more challenging. Well, then you can kind of, after your general motor speech assessment, really hone in on those specific articulatory deficits. But for a comprehensive kind of 15 to 20 minute motor speech assessment, you're not going to give a standardized articulation test, and you're not going to probe each phoneme in every position of words. It's just not going to happen. Okay, so again, I just said these are the general tasks you might utilize to get some information about articulation. So in general, when I'm doing an informal motor speech assessment, I like to get a general idea of some of these articulatory deficits, and then I always kind of try to take data of some specific deficits that I notice. So I might give an example of a word target that they were trying to say and then kind of transcribe or provide their deficit to give just an example of an articulatory deficit. Okay, so we know that almost every part of motor speech, it's combined systems. We have to have phonation, respiration, resonance, articulatory precision for all of that. We know AMRs, we're talking about alternating motion rate, is going to give us some information about articulation because we have rapidly moving repetitive movements. So I provided, we know what the tasks are. So for AMRs, I want you to say pa 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 for as fast and as long as you can, keeping that steady. There's many different prompts you can do. In the real world, what I typically say is, okay, I want you to say pa 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 as fast as you can, and I will tell you when to stop. So they just keep going until I tell them. In general, I like to provide, like I've said before, a model of the expectation of really what that model is, because if you just say fast and as long as you can, patients might just say pup, 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 and not understand the expectation. Is that really a rate or prosody deficit, or is that truly just, I didn't understand the expectations of the task, and there really is no deficit. It's just I didn't have enough context of what I was supposed to do. Okay, so I put some just general information about AMRs, some of these, the data for that. I have later on, I took a screenshot and I have on Blackboard another source. It's the Clark, I believe it's my Clark resource that gives some more context of some specific data. But in general, 5 to 7 reps per second is going to be kind of consistent with precise articulation. And then just for me, because I like to kind of categorize, if I'm saying slow and regular AMRs, that might be flaccid, that might be spastic. Slow and irregular could be ataxic or hyperkinetic, or more blurred and rapid could be hypokinetic. That's something I like to do. I like to kind of, I'll put my data or I'll time afterwards and record AMRs and put how many how many reps per second, kind of get that average. However, that data in and of itself does not connect the dots, right? So we have to understand if they're really fast or really slow perceptually on top of that data, what type of dysarthria may that help us with. I will say though, some patients will surprise you with AMRs and SMRs. I mean, again, you're going to look kind of at your grid, if you want to use the Wong 2002, whatever you want to use, and you start checking off the different areas for the different types of dysarthrias. But unlikely you're going to check off every box in one type of dysarthria and it's going to fit perfectly. It's the general consensus given site of lesion and medical diagnosis that kind of helps solidify what type of dysarthria that person has. Fine. All right, and then for SMRs, okay, we understand that we're going to have the patient say pataka as fast and as long as they can, and until I tell you to stop. So pataka, 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 and then for some patient populations, sometimes that's just super challenging. So for pediatric populations, you might say patty cake, patty cake, patty cake if that's easier. Normal rate is about 5 reps, 5 per second of getting through pataka, 5 per second. And typically SMRs are not they don't have this like hallmark of, it's not going to distinguish the type of dysarthria based on just SMRs. AMRs are better at distinguishing, but SMRs are better for understanding kind of the red flags for apraxia. So it's not uncommon for someone who has acquired apraxia may be able to do AMRs better because that's an easier program. Think about it. The place, manner, and voicing isn't changing. That program's pretty easy versus that pataka is a really much more complex program, pataka, which can be harder. So just something to consider looking at this holistically. So we're talked about the domain area, some general things you may want to do. Again, there's resources in your textbook. I provided ample resources, which I'll pull up for you on Blackboard. And none of this you have to memorize because in the real world, you're going to have a screener or kind of your protocol and you're going to follow through with your patients, but there's nothing to memorize. There's nothing like, it's not rigid. It's fluid and kind of patient needs on what you have to assess into the depth. And yes, we'll do AMRs, SMRs. We're going to have prolonged we're going to look at each domain system or domain area. And something we're going to do for all of our patients is stress testing. We're going to stress all of the systems. So when we see our patients at bedside, we can kind of finish up just the motor speech, oral MET cranial nerve assessment, typically in the real world pacing about 15-20 minutes in total, and do a swallow evaluation, kind of putting that all together. But when we think about these tasks, we're not necessarily stressing each system. Most of these tasks, prolonged AMRs, SMRs, repetition, even our conversational pieces, we might have a patient phonate or use all of these systems together for less than a minute, 30 seconds at a time. Especially with assessment, we kind of take on a lot of that burden and for expectations where we're talking quite a bit, and then we're eliciting very specific tasks, which might not be super cumbersome on the systems. And especially with the patient, with the neuro populations that we serve, we have to do stress testing. And by stress testing, we want to, for a prolonged period of time, have that patient use all of the systems together, which is speech production. So a task that we can do for this is having patients count 1 to 100. Now, in the real world, are we going to necessarily have them continue to count 1 to 100, like spend I don't know how long it would take. Does every patient count 1 to 100 and we just wait to 100 and then stop? No, depending on kind of the neural workup in our patient populations we serve, in general, we want the patient to kind of have a connected sample, and an easy task to do is counting for 3 to 4 minutes or so. And what we're looking for, is there any rapid decline of articulation? Is there a rapid change after prolonged speech with resonance? All of a sudden, is the patient completely intact and we're now all of a sudden noticing hypernasality, noting significant changes in phonation or vocal quality, or articulatory imprecision? Is that getting worse and worse as the patient continues to speak? And then if we stop phonation and those systems together with a break, doesn't improve. And what we're looking, the reason we do this task is because we want to kind of rule out and look and see if there's any concerns with neurotransmitters in like muscle firing, specifically with myasthenia gravis. So myasthenia gravis is one of those populations we've talked about, or disease processes we've talked about, where there's going to be a deterioration of the receptors with continued transmission, talking about, synapses with that neurotransmitter that's being sent over and over again during volitional continued taxing of the system for us speech. When those muscles are firing with myasthenia and those neurotransmitters, as that continues over time, it's going to be less efficient and we're going to see a decline. So if you have a patient that they're ruling out myasthenia, or there's a concern about this diagnosis, or we're just not sure, either way, we want to get a connected speech sample. The easiest way to do this is having the patient count, just really a rote task, and seeing if there's a decline. So I have a quick sample of someone who has myasthenia and kind of looking at that change. So I'm going to pause and pull up that sample. All right, this sample is just listening, so there isn't a video with it, and this patient or person who has myasthenia just has some dialogue with that. So I've seen patients who have had myasthenia gravis crisis in the hospital, and they can have a really abrupt change in kind of the parameters for speech production, where it's within a second or two that you notice a significant decline, which is the case for this patient. We will watch in class a case where it's less obvious. It's not this abrupt 1 second completely intact speech, and then all of a sudden there's a significant decline. It takes a little bit of time with continued speech, but this is a more extreme example. So let's listen.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 20.
So clearly this patient wouldn't need significant stress testing to be able to, for us to be able to perceive the significant decline with regards to speech production. Here we go. Here we go.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 20, 21, 22.
So this is an extreme example of a decline with continued volitional speech. And with individuals who have myasthenia, once that system is there's a break for improvement of rest, the person's speech goes back to their baseline status, whatever that may be. So a person with myasthenia needs medical management, typically Mestinon, to be able to kind of manage from a neurology standpoint, kind of manage the neurotransmitters and figure that out, because that is the etiology is kind of that neuro piece with the neurotransmitters. So with every motor speech assessment, you're going to have some stress testing of all of the systems together. All right, so here we go. So prosody, let's kind of talk through prosody, what we're kind of looking for. We understand prosody, we have, it's stress, it's intonation, it's rate and rhythm. So with stress, things that we kind of want to be like thinking through when we're listening to an individual, are they putting the right kind of stress on the correct syllables? Is the emphasis on the right syllable? Kind of looking at that. Is there any concerns with regards to stress and intonation with pitch, loudness, duration? And we can evaluate this with contrastive stress tasks. So by having different sentences, and I'll pull up an example when we're looking at the Swigert assessment, where we will have a patient put different emphasis on different syllables, and can they shift that as well? So one, informally, we can kind of perceptually kind of see stress and intonation within, conversational speech or connected speech. But also we can kind of make this a little bit, add a little bit more control to this, and I'll make this a little bit more of an objective task by having contrastive stress tasks. So where we have sentences where, let me just pull it up now, where we have a task here. So oh, this is the 30-page one. Let me get there first. My apologies. Okay, here we go. Let me pull this up. So here's just a really simple example, contrastive stress. Todd likes apples. And then, we can kind of change the task to indicate stress. So can they mimic our stress where we put the stress on different words? Todd likes apples. Todd likes apples. Can they shift that? So, increasing pitch. Can they change that variability with increasing pitch, increasing loudness, pause, and rate? So that's just a very, very simple example. And we will go over these resources in a little bit, looking at some of these different tasks that we can utilize perceptually, informally, to understand the different domain areas such as prosody. Okay, so here we go. On things that we're looking for informally. Are there appropriate changes in pitch, intonation, and kind of understanding that when we're talking to patients, we're really doing this in a kind of a sterile environment, but in general, we're trying to do our best and kind of in this 15 minutes or so, are there significant concerns with stress and intonation? Rate is easier to identify. Rate too fast, too slow, and I have some data or some normative data there we can look at. But stress and intonation we want to have some conversational aspects, because if we're doing really just rote task or word repetition, or we're doing just some of the AMRs, SMRs, and prolonged we might not get a great idea of like the depth of concerns or lack thereof with stress and intonation. So things we can do is imitate sentences with varying emotion, making statements, making a sentence a statement versus a question. It's just a very easy for us with an intact prosodic domain area, easy for us to say, how are you? How are you? And just kind of change some of these statements with our those prosodic features over the message that we're saying. So for rate, I know perception, we can say, oh, it's too fast, that's too slow. But if we're looking at some normative data, normal rate is anywhere between, this is quite a big variability depending on kind of the context that we're talking, anywhere between 130 and 220 words per minute, 3 to 5 syllables per second, 12 to 20 syllables per breath group. So there is some data out there to kind of get us a better idea with regards to rate and rhythm. Okay, so these are just questions. I mean, they're not going to be questions on your assessment, but this is kind of the questions that you're kind of asking yourself or talking through as you're seeing a patient. So when you're seeing your patient, you kind of start with, you start with orientation, you're getting some more case history information, you're getting the patient's perception of their concerns with their voice or lack thereof. We've already kind of done a chart review for that medical piece and etiology, if that's in the chart, or any imaging, fine, any past medical history or neuro history. And then we're starting to do, we're doing these kind of isolated tasks, AMRs, SMRs, prolonged we're doing, we're moving through our systems, we might do some prosodic, so probing for prosody and intonation, rate, and inflection. We're doing some stress testing, having them count to 100, etc. These are really, we're kind of like, these are just like pulling things out of the air, little pieces. And as we're pulling these small pieces of data, everything we're doing from cranial nerve to oral mac, you're kind of saying, okay, what did I just hear? Yes, fine. Can I take data on that? But like, what does that mean for my patient who likely has dysarthria? If there's an atypical which we'll talk through the domain areas with deficits in a second, what does that really mean? Are we concerned about phonation? Are we concerned about respiration? You're just kind of already starting to take that data and putting it into respiration, phonation, resonance, prosody, articulation, or the unknown. There's going to be pieces that you're just like, that's deviant. I need to think this through, but that is a red flag, and I'm just not sure where that red flag fits, and that's okay. So you're taking your oral motor exam, you're taking what you know about sight lesion, you're kind of putting all of these data points together into kind of like a summative statement for your hypothesis of, okay, in this moment right now, if I had to pick a dysarthria, What am I thinking and why? So, this isn't a moment where you just like stop what you're doing in the middle of the patient's room and go, okay, I need to ask myself these 7 questions from my motor speech PowerPoint now. Let me ask myself. No, as you're seeing your patient, whether it's aphasia, motor speech, dysphagia, voice, you're just continually to refining your hypothesis with the data that you're collecting, because at the end of it, especially in acute care, after your 15 or 20 minutes with the patient, you already have to kind of define that dysarthria, be ready to write provide your patient education, connect with the physician, and write your note. You don't have these, days or hours to contemplate. You're doing this as you're seeing the patient, and it takes practice. So these are just kind of things that I am thinking to myself as I'm doing my assessment. And I will say it gets easier over time, but there are still patients, I when I'm consulting or we're talking about patient care, where there's pieces that may just not fit, these puzzle pieces may not just fit in quite yet, and we might need a little addition, we might need more information or additional probing or other medical professionals to help figure that out, and that's okay. So this is again a repetitive slide from maybe PowerPoint 1 or 2, where all I'm trying to say is we do a lot of isolated skills assessment of each, phonation, resonance, prosody, articulation, blah, 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 blah. And that's great. I mean, a prolonged ah is wonderful and it's helpful and it's part of that comprehensive motor speech informal assessment. That's kind of like an isolated task, like that left column. But we have to put all of that together perceptually, because that's how we're going to kind of understand the severity of how that person who has dysarthria impacts their communication with others. It's going to help us kind of understand the impact of that individual who has dysarthria on their communication. So yes, we do isolated tasks to look at the domain areas. Then we have to put it all together in connected speech to figure out what's really going on, because in the real world, we can look at one domain area and it can be super deviant. If we're just looking maybe at resonance and you're looking, and we'll talk through this, but you're looking at resonance and they have hypernasality, nasal emissions, and you're just looking at that piece. But then when you put all of the systems together, wow, that person has excellent articulation. They've got wonderful awareness of deficits. Phonation is fine, and kind of respiration is actually pretty efficient, although there's nasal emissions, and kind of making that a less efficient system objectively. The patient may be able to kind of compensate for some of those deficits. That's why we have to look at them both individually, domain areas, and look at it together, because if we just look at objective data, it may conflict with listening to that person's speech perceptually. So here we are. We've kind of done our informal assessment, and we've kind of understand anatomy. We understand kind of oral mech, neuro piece, and we have to kind of figure out, which we've been doing all along, what are the domain areas that are in deficit, and what are those deviant characteristics that tell me that respiration is in deficit, that phonation is in deficit, and which ones are impacting communication or not. And here's the thing. If the patient perceptually does not seem to have dysarthria, they don't have dysarthria, because one of the primary diagnostic criteria for diagnosing dysarthria is the perceptual characteristics of the deviant speech characteristics. So if you're not seeing deviant speech characteristics in respiration, phonation, resonance, articulation, or prosody in one or all of those areas, the patient does not have dysarthria. So if the person's speech is abnormal, we have to define those deviant speech characteristics in those 5 domain areas. And just to kind of bring us back, this would be an excellent checklist to kind of put in an informal assessment. Is phonation voice a concern? Yes or no? Is there a voice tremor? Are we seeing pitch breaks? Are we seeing harshness, hoarseness, breathiness, etc.? Okay, so now I have a checklist of things I can kind of mark off, or other, just cul-de-sac, diplophonia, whatever it may be. You can kind of get a working list of things that may be in deficit, so you can kind of really see if voicing phonation is a concern. Same thing with prosody, monopitch, monoloudness, reduced loudness, all of those things for prosody. And again, rate would be in there too. Respiratory control. Are we seeing short phrases, audible inhalation, reduced loudness, etc.? Well, we can start looking at each of these domain areas. Same thing with articulation, prolonged phonemes, irregular breakdowns, imprecise vowels articulation, resonance, rate, etc. But this is kind of how we start marking off on our list which domain areas are in deficit, because if there is a domain area that's in deficit, we have to check for stimulatability. To kind of look at this another way, here's respiration. I have two columns here. What can be wrong? Muscle weakness, abnormal tone, incoordination of like the respiratory muscles for breathing. And then I have here like a working list of things that you might hear. So reduced overall loudness, mono loudness, short phrases. That could be because of weakness. Reduced overall loudness or mono loudness could be tone or combination of all of these. So kind of perceptually, this is what I might hear and see. And then from a respiration column perspective, these are the things that might be physiologically in deficit or wrong. So here we go. I've said stimulatability about 50 times, totally fine. So we look at each domain area and we say, yes, no, are there deficits? What are they? What's their evidence? Respiration, phonation, resonance, prosody, articulation. So then I'm going to go through each one of these different domain areas. So if respiration's in deficit, we have to probe for stimulatability and see if we can change, modify, adapt, shape, improve that deficit area in our evaluation, because if we can shape or probe that area, there's stronger evidence that we may be able to target that area in treatment. So here is a couple things you may want to ask, your patient or try. So if respiration is in deficit, you're seeing kind of atypical posture, clavicular breathing, reduced breath support, you can just ask your patient, okay, this time I want you to take a bigger breath, and I want you to start speaking at the beginning of when air comes out, for example. And if the patient can do that and it improves vocal intensity or improves that kind of efficiency for breathing for speech, guess what? That might be a wonderful compensatory strategy or domain area that in therapy we're going to look at further or provide goals or a lens to work on in therapy. We'll talk about in interventions about even manual manipulation and movement. So there's certain things that we can do, pushing in on the stomach, providing posture changes, working with a physical therapist, and using different types of compensatory strategies to work on posture to help with respiration. So if there's a deficit area, you have to check for stimulatability. That's part of the evaluation piece. Now, if there were no concerns for respiration, guess what? You're not going to probe stimulatability because there's nothing to change or adapt. So part of your Unit 2 project is for every domain area, you're going to have to give resources or direction on how that clinician would assess stimulatability in each of those 5 domain areas. And I have other resources on this that I'll pull up afterwards. Same thing with phonation. Again, looking at these columns, what you may hear is breathiness. Well, that could be related to reduced laryngeal tone or vocal fold paralysis. If there's strain or harsh vocal quality, that might be excessive hyperadduction or increased tone at the level of the glottis. So I just took what you might hear perceptually and what may be wrong, possibly. Same thing with resonance. If you're hearing hypernasality, what does that mean? What could that mean? Reduced velopharyngeal closure, hypernasality, increased tone. So here are some ideas. I mean, again, there's no need to memorize these, but here are some ideas to check stimulatability for resonance, to check stimulatability for phonation. Very simple task in the moment to see if that will change some of these. I will tell you, in general, if you have reduced velopharyngeal closure, and that's because of some paralysis or weakness or a neurological perspective, unlikely that we're going to see much change with stimulatability because that patient might need more prosthetic or medical interventions. However, you still want to see if we can shape that a little bit. Same thing for phonation. Having the patient, if they're using an atypical pitch, try to match your pitch. Try to easy onset with voicing with strain. Just trying to adapt and shape in the moment after finding out that area is in deficit. Same thing for articulation, what you may hear, what the deficit may be, and then, stimulability. Something that seems so common sense and simple is a general dysarthria compensatory strategy that seems to help many patients, which is just over articulating. When a patient over articulates, likely they're going to slow their rate down, and hopefully that will increase their intelligibility and kind of adapt. I will say, in an acute care bedside evaluation, with stimulability with articulation, you won't have the luxury of, again, giving a formal articulatory assessment and assessing every single phoneme distortion or placement or voicing, all of that. But in general, can we get that patient to over articulate? Can we get them to slow their rate to compensate? And then in therapy, there might be specific clusters or deficits that we might see related to articulation that we can adapt and shape. And then same thing with prosody. Again, things we might hear, monopitch, slow rate, etc. Again, nothing to memorize here. And then, stimulability. What can we do? Can we have the patient slow their rate down? Unlikely you're going to have them increase their rate, to be completely honest, because increasing rate is likely going to affect intelligibility in a negative way. But can we, for many of our patients, slow their rate? Increase pauses, phrasing. Can they even just mimic or model our prosodic features? Because that could be something we can work on in therapy. Imitating basic intonation patterns. That means there's potential to shape that. Okay, so now I'm going to pull up resources that I said I would. Okay, so there's plenty up here. So this is just so the source for dysarthria, it's old, it's like 20 years old, but it's still good. It's an informal assessment looking at different domain areas. This one's the 4-page one. Let me pull it up. What I like about the Swigert resources, and there's a 30-page resource I'm going to give you in just a second, is that it looks at, it's a perceptual evaluation. It's functional for therapy and inclined for us to look at stimulability and like shape our evaluation for therapy goals. All right, so again, this is form C1, this is the page, and I'm going to pull up the 30-page one in just a second. I'm not saying this is a perfect informal evaluation, but what's published out there, this is probably the most user-friendly for a clinician. So when you're doing your Unit 2 project, you're not just going to copy and paste and say, oh, I'm just going to give C1 the perceptual dysarthria evaluation that Swigert did. No, but you can adapt and model and utilize some of these resources. Does a very basic oral motor evaluation, again, not perfect or comprehensive, looks at orientation, has a nice way of looking at AMRs and SMRs, things we've talked about. I like that it has some other things. It's looking very, very basically. Any concerns with memory, hearing loss, again, very basic. Prolonged check yes or no. Is there concerns with some of these vocal characteristics? It looks at respiration, domain areas during conversation or reading tasks. Respiration deficits, phonation, resonance, articulation, prosody, has contrastive stress. Fine, but here, this is what I really wanted to show you is the 30-page document. Let me see if that's going to pull up for me. All right, so the 30-page, let's see. All right. Let me pause so I can pull up the appropriate document. Okay, so here it is. I have the 30-page document. This is from, made a copy. So the first page is C1, which we talked about. But what I like about this form from Swigert, this resource, let's pull it up. Here we go. Is that it gives really robust directions on kind of what you're looking for, how to kind of go through a chart, how to maybe ask your patient certain questions. It's just a nice 30-page informal resource to maybe help guide a clinician in doing an evaluation. Here, let me pull it up. So it gives explicit information. It's looking at structure, how to really assess jaw, lip, tongue movement, what you're going to do, the expectations. Again, not perfect, but it's a little bit more clinician friendly. Have the patient protrude their tongue, looking for certain things. Elevate the tip of the tongue. It just gives a nice, more user-friendly guide in looking at some of these different areas. Looking at cognition, looking at AMRs, SMRs, prolonged these are the instructions related to that informal piece. So again, contrastive stress right there. All right, so as we're doing stress testing, again, there we go. All of these things kind of complement what we were talking about in lecture. So then there's a fake patient here that has it kind of filled out the way that they would do it. And I'm getting to the part, I promise you there's a point that I'm looking at all 30 pages of this. I promise you that. Okay, promise, getting there. Scrolling, scrolling, scrolling. Again, a few mock patients that you can see filling this out. Again, this reflects kind of our PowerPoint, but it looks at each domain area and questions you want to ask yourself to make judgments about respiration. So here we go. What a great resource. We're going to look at respiration, what you might perceptually hear, what could be wrong. How do we assess respiration informally? What are some general norms? What are some questions you want to ask yourself as the clinician to yourself to kind of see if there's any areas? And then if respiration's in deficit, what do I do for stimulability? And this resource goes through each domain area, phonation, resonance, etc., and goes through each domain area to kind of see how you would maybe look at that perceptually, how you probe that area, in addition to looking for stimulability. So this is a 30-page document that's a wonderful, user-friendly resource. All right, let me pull up the other, here we go. So the other Clark assessment, I think I already pulled it up. Maybe I didn't. All right, I will pull it up. This is an 8-page document. Here's the source. But this is in your PowerPoints as well. How do you do a chart review? What are some things you're looking for? Fine. What I like about this, here we go, is it looks at each domain system and then perceptually what's a task that we could look at or do, and what's a general standard, normal, what would be like a standard of performance. So respiration, perceptually, this is the task I would look at. Fine. Here's a standard or a measure that I would use to kind of compare if that's normal or not. And then what's a physiological test we could do? Vital capacity if we had instrumentation. Same thing with phonation, respiration, articulation as well. So this is just another resource of looking at, if we're thinking there's impairment, this might be what the deficits could look like. This is impaired. So just make sure you're looking at, if you're using this resource, that you're not using, you can look and see, oh, this would be a concern for disability or in deficit areas. So again, here we go. Here's a task, here's the norms. Here's the task, here's the norms. So just another resource of looking at some of these deviant characteristics. Has a nice table 9.6 that's looking at intelligibility, which we'll talk about in just a little bit. Speaker variability, listener variability, environmental variabilities, and they have another resource I made for you that should help kind of connect the dots with that. And then another task from Clark. Here we go. Looking at different tasks that we would utilize for different domain areas, and where you might see this in a standardized test. So count to 20 on one breath. Oh, that's also in this formal assessment for dysarthria. Looking at some of these different tasks that we might do, and even finding evidence that these tasks have been elicited from a standardized assessment. So just another visual, another resource at looking at some of these different tasks by domain area and even by assessment. So you can say, oh, here we go. Counting 1 to 20 on a breath, that's in 2 different standardized assessments, and here's some evidence to support that. I'm just trying to give you some resources here that might be helpful in making your assessment. Okay, so here we go. We're going to transition now and very briefly talk through some standardized assessments that are out there in the real world for dysarthria. And we're going to move forward from there. Okay, so we're moving on to PowerPoint 4. This really is just looking at the formal assessments that you may have access to or you may not have access to when you're a working clinician. But I think we should still talk about the standardized assessments because there is value to some of these standardized assessments. So I know I kind of talked somewhat harshly about some of the weaknesses with regards to some of these assessments. However, I will give you an overview of these assessments. If we were in class, I would actually bring in these assessments and kind of have a little bit of a hands-on activity, but I mean, we'll make do. So I just put pictures of the assessments. So so that'll work. So I just took the actual pictures. I took pictures of the assessments from the clinic, and then I put the pictures on the PowerPoint, trying to make this a little more authentic. So, anyway, here we go. So let's talk through them. Kind of what you're doing with these assessments, like what the task is, and kind of how you're using differential diagnosis if you are with these motor speech assessments. And then from there, I'll talk through some of the advantages and disadvantages of each assessment. There's a part where I have kind of a motor speech, not motor speech, oral MAC apraxia portion. I'm going to hold that part because we talk about it in Unit 4 anyways. So I did all assessment in here, but honestly, we're just going to streamline this and talk about the dysarthria assessment. So the first one is the Frenchy dysarthria assessment 2. I feel like this is the assessment most people are familiar with. So let's talk about this. So actually, I can pull the PowerPoint up. Sorry about that. With the Frenchy, so now you can see it. So you can see our stained pages. You just can't hold on to them now because we're not in person. So for this, you're going to rate each specific task by level of like deficit or difficulty. And then from there, you're going to look for patterns to identify kind of the general site of lesions. So for example, here we go. So here it is, a task. Ask the patient to say this explicit target. And while you listen to the change of quality. So may pay from nay bay. So this is kind of looking for resonance. So then you have this scale for, again, this is just because we are not in person, I'm reading it to you. You have this scale. So like, an A is going to give you normal, you'd say normal resonance, no nasal emissions, to B. It's kind of like a Likert. So like from like deviant, like significant hypernasality. And then from there, talking about absent nasal emissions or hypernasality. So you're going to have these specific tasks, and then you kind of have to rank or rate on the scale if they're deviant or not. And from there, you kind of fill in and check those patterns. So like, it's hard to see here, but like you have a cough task, a swallow task. You have at RASC, looking at some of these oral, I know it's hard to see oral motor, looking at tongue, intelligibility, laryngeal, palate, jaw, etc., lips. And then you kind of like take your data on where you are on the scale, and then it gives you somewhat of a profile at the end when you kind of put your responses together, and it's going to kind of give you a general idea if this is more of an upper motor clinical presentation versus upper and lower motor neuron clinical, extrapyramidal, cerebellar, lower motor. So it looks at it from more of like a general pathway perspective, and I'll talk about the pros and cons in just a second. So here are the tasks. You're going to look at some reflexes, respiration, lips, symmetry, do kind of an oral MAC. Again, it's a very specific expectation for the patient to do each one of these. Palate, laryngeal. You're going to look at so maximum phonation time, MPT. You're going to have your patient kind of glide up and glide down, looking at pitch. The thing that I find interesting is that there's nothing that's looking at vocal quality. So there's that one explicit question for rating on vocal quality, which I think is so interesting, looking at the tongue at rest, but I just kind of listed what those kind of tasks are. And then it looks at intelligibility. And again, the end of this entire lecture is like, what does that really mean? But intelligibility, looking at the patient has to read 12 single word cards. So it's a really contrived intelligibility task, not very functional. the listener already knows the expectation of what the patient's going to say, and they're reading or saying out loud 12 single words. And then you have the patient read 3 to 5 word sentences. But the sentences are interestingly because they're very predictable. So if the patient is somewhat unintelligible, the listener can still kind of put the pieces together of what that sentence may be. Here's the thing. Some of the sentences are ridiculous, like he's not my type. I just think that's a ridiculous sentence. Fine, go to bed, you have to pay. But you're using these tasks, you're having the patient read these words or sentences to get a better idea of intelligibility. However, it doesn't give you that kind of functionality of conversation. So intelligibility and conversation rating, the patient, does the patient, it's still not supernatural. So there is an intelligibility section, but it's not authentically maybe looking at conversational intelligibility, because even their conversational intelligibility task is looking more at comprehensibility, which I'll talk about in our next lecture, versus intelligibility. Another one, an oldie, so 1982, not that long ago actually, the dysarthria profile. So it's going to evaluate respiration, phonation. I have a list of there. You're more than welcome to read it. Again, I took a picture of what that looks like, the rubric or scale, or the data sheet. So it looks very similar to the domain areas we're going to put in our Unit 2 project. And then you're going to score them kind of quantitatively, kind of ranking. You have I'm looking at this now. So you kind of look at these different areas. So here, ability to repeat initial consonants is the task. Normal, good, fair, poor, none. And then from there, you take those where you rank them, and it turns into a score. Here's this. There it is. Fine, fine, fine. I'll talk about the pros and cons in just a second, but it's really just a profile. Some very explicit tasks, and then you kind of say normal, good, fair, poor, none, but it's pretty subjective still. Like I said, there isn't one formal assessment where you're just going to give, and it's just going to magically tell you the type and severity of dysarthria. And then from there, you're magically going to kind of know what to do in treatment, because a lot of what we do requires kind of the perceptual piece and putting all of those domain areas together to figure out that diagnosis, and because it's not prescribed, and from there, then figuring out stimulability and then treatment interventions. Okay, so here we go. So this is my opinion, and as a clinician, and maybe you'll disagree, and that's okay. Again, I said in the real world, you're likely going to use, maybe you might have access to some of these assessments, that's great. You'll likely use a combination of, you'll likely utilize some informal assessment to help guide your intervention at first for your informal evaluation. However, what I like, or something I find is more clinically intuitive, here's what I like, it's more clinically intuitive for goal writing, is the Source for Dysarthria by Nancy Swigert, and her literature is in motor speech and dysphagia, but I made copies of the 30 pages of directions for her book and the appendix, the different like references and appendices, so you have that informal resource to maybe help guide you. So I kind of labeled it by the different pages. So like if you look at it, it says like C1 on the top of the page, C2, etc. But gives you some like nice information about an oral motor evaluation. Is it perfect? No. Will yours be more robust? Absolutely. It gives you some information on just in general, because we don't have blinders on. It gives a little general idea of like probing cognition or communication, like 2 or 3 questions. So not sufficient. And I'm not making you do an aphasia battery. Of course, you're going to assess orientation, but you're not responsible for making a cognitive assessment. That's under C1. AMR's SMR, C1. The next page is C2, prolonged and then looking at the characteristics by domain area. There's a whole section on stimulability, speech characteristics and conversation, reading, contrastive stress and intonation, and stress testing. So all of those things I've kind of provided in the PowerPoint, they are also laid out through this other informal like resource. So continuing on with that resource, I gave you the 30 pages of resources. A lot of it has quite a bit of directions. I do like that it gives a description on how to assess each domain area, questions to kind of ask yourself like I talked about before, and then just some general suggestions on how you may probe stimulability if that's a deficit area. It has some other resources of looking at how does this, this communication deficit affect life, ADLs. It gives some information on word and sentence level for assessing articulation. These are the different appendices in the back. You have these. It gives you the prompt for the grandfather passage if you want to use that, prompts to elicit conversation. And then it goes through ASHA's functional communication measure. So ASHA for each domain areas, peds and adults, has kind of like a 7-point scale of like from intact to severe for every domain area. So for dysphagia, voice, swallowing, or dysphagia and swallowing, the same thing. Dysphagia, voice, motor, speech, intelligibility, aphasia, etc. They have these different scales. So we have kind of like a working idea of severity. ASHA put this together. Not common in every domain, every medical setting, but it's out there. So those resources in there. The thing that it doesn't provide is that there's not any norms, which makes sense. I mean, again, it's very perceptual, but it gives you a better kind of template of what you may want to ask your patient. So here's the pros and cons. So for dysarthria profile, so some of the tasks are excellent, may be helpful, but it's not going to help with diagnosis of the specific type of dysarthria. So it does like oral mech, oral motor, kind of these like tasks that we would kind of utilize in a motor speech assessment. But the dysarthria profile doesn't then, from your data, help you define all of the different types of dysarthria. So that's a disadvantage. The front sheet has patterns of behaviors which help with diagnosis, upper motor versus lower. But actually the data for the standardized assessment per group is very limited. I think of like 30 patients are part of the normative sample. So even that data is loose for interpretation. And when we're looking, if you kind of give that, which you're not going to do because we're not in person, which is fine, but even the tasks that they elicit, they're not thorough enough to kind of really kind of deviate or kind of like parse out the different types of dysarthria. And it's missing some kind of important pieces, like there's nothing on vocal quality, for the perceptual piece, and it doesn't necessarily gear you to planning for treatment. So as a clinician, the Swigert book, I know it's a book and they have kind of an informal like screening tool in the 30 pages of like resources and directions. I feel like that really guides us as clinicians in planning and kind of looking at each domain area, looking at some general expectations, and then kind of changing our vantage point, looking at stimulability to help us figure out what's next in treatment, because that's all of Unit 3. Disadvantages: there are no norms or just general expectations, but when you make your resource guide, you are going to put some of those general expectations. So, what should AMRs look like and SMRs? What should maximum phonation time look like for prolonged ah? You will put those resources in there, which should be helpful. So that's that Clark resource I pulled up before, and has some of those norms that you may want to use just to kind of put that together. And then I have a list of a couple oral mech exams that are out there. I will tell you, it's very unlikely you will be giving a standardized oral mech exam because it's part of a swallow evaluation informally. It's part of a motor speech evaluation informally. So if you're thinking of giving a standardized oral mech exam, I guess the only setting you'd do that would be like a university clinic or outpatient. Don't repeat your task in the sense that if you did a swallow evaluation and did a cranial nerve, this is what I'm really trying to say. If you give your dysarthria assessment first, think about what you've already done with your patient and don't repeat it. So if you've done prolonged ah and checking vocal quality with your patient for part of your swallow evaluation or part of like your voice piece, don't do that task again in your other part of your oral mech. So some of these tasks, don't just repeat them because you feel like you have to do it for voice, swallowing, motor speech. Just do it once. Okay, so I'm not going through the test of oral structure and function. These are oral mech assessments out there. These are resources for you in the future if you ever have the opportunity to do a formal oral mech standardized assessment, that's fine. The oral mech mechanism screening examination out of St. Louis, there's one out there. It's a screening tool. It has some resources for you. I just kind of outline what that may look like. And this is what I wanted to show you. So from there are some norms for AMRs and SMRs by age group. So I just put those up there for you as a reference, which might be helpful for you. So I just thought this was a nice resource for you. And then these are pediatric ones. So the most Marshalla Oral Motor Sensory Motor Test is a pediatric like oral motor assessment. So if you have a kiddo who you think has, we haven't even talked about it, childhood apraxia of speech and dysarthria and has like really some like motor concerns, this is a really nice pediatric friendly systematic way of kind of looking at all of the structures of resonance, respiration, phonation for dysarthria. So if you have a kiddo on your caseload who you think might have some like, I've utilized this assessment in outpatient, even when I was doing some university supervision a couple of years ago with some pediatric patients. It's really user friendly for kids. There's some really nice visuals. You know, there's some great like toy based probes to kind of look at some of these things from kazoos and kid friendly pictures. And it's really set up really systematically to be kind of pediatric friendly, but it's for age 4 and up. So just saying that's out there. And then the rest of these, I'm not going to go through because we're going to talk, some of this is more praxia based later. So I wanted to go through the assessments that are out there. And then, where is it? Let me pull this up. I just put a resource up there. One of my research colleagues published some information about like the realities of access to standardized dysarthria and intelligibility measures in the real world, and probe medical speech pathologist a couple years ago, and she was looking at just to see what people were utilizing for intelligibility and what assessments they were using, and Frenchy, etc., and found that 35% of all of the speech pathologists surveyed who were practicing working in the area of dysarthria didn't even have access to even one standardized assessment to look at intelligibility in adult populations or dysarthria. And 2/3 of those individuals said it was because of because of the cost of some of these and accessibility. So I just wanted to show you there is evidence, there is research to support that. The reality is not just my opinion is, you know, there are assessments out there and there's great things and there's advantages and disadvantages of all assessments for motor speech, etc. But you simply may not have access to them. So you don't have to, I mean, feel free to read it if you want, but it's a 20-page analysis. It's kind of like systematic look, you know, review, snapshot. And in short, most speech pathologists are not utilizing standardized assessment. Whether that's good or bad, I'm not making an opinion on that, but many just don't even have access to it. So here we go. Last PowerPoint, we're going to transition and talk about intelligibility and have a conversation about that in our synchronous portion as well. So I'm going to pull up that PowerPoint. All right, so we're on the last PowerPoint for Unit 2. And I will say the majority of the slides within PowerPoint 5 are repetitive from the previous PowerPoint. So if we were in class in person, this would be kind of review for the next time we went in person, but given that we are asynchronous, we do not have to repeat the same information. So lucky you. So we're going to spend our time talking about the difference between intelligibility and communication effectiveness, and really bypass the majority of the slides because they are review from the last slides that we talked about. So again, this is review from last lecture or PowerPoint talking about how we look at each subsystem kind of individually, and yet we have to put them all together perceptually to kind of understand the severity and the impact in the real world with communication versus just looking at a task like, you know, maximum phonation time versus a connected speech sample will give us more information, but both are important. Okay, so when we're thinking about a connected speech task, this is going to tie into intelligibility. There's many things we can do. So things that we may consider for a connected speech task may include having a patient read a paragraph if they can read, or have the ability to do so, maybe utilizing the rainfather. Wow, let's put two different tasks together. That's interesting. My decoding skills are impaired. Grandfather passage or the rainbow passage. We can look at conversation and get some other information until, for example, like for conversation, it may be challenging within a conversation task in your assessment to really kind of understand communication effectiveness, which I will explore in just a second. Many standardized assessments that are out there for DSAR-3 or motor speech will have an intelligibility task, like a word level or a sentence level. And we can have a conversation about, is that enough? Is that going to be enough information for us? And it's not right or wrong, but when we're thinking about probing intelligibility, probing communication with regards to motor speech and dysarthria, we want to get a really good vantage point and viewpoint of what that patient is going to look like with communication partners. Now, maybe right after a CVA or a stroke and there's significant reduced intelligibility, maybe word level is appropriate or a really structured sentence level. But when we're thinking bigger picture, we're going to need more than an intelligibility task that's at word or sentence level. So review deviant speech characteristics. Yes, we've talked about them. This is review from last PowerPoint, exactly from there, looking at the different domain systems. And we spent last PowerPoint talking a lot about stimulability. So if there's a deviant area, such let's just say respiration, it's based on what was wrong. So I heard or saw you do this. Can we try this to change this, or can we adapt this? You know, for example, for respiration, I noted, again, maybe you wouldn't say this to a patient this way, but posture, maybe they've got reduced breast support. I noticed that you're sitting like this. What can we do to maybe sit you up a little bit better? And let's try that task again. Or I noticed that when you're breathing, you're not taking the power of your breath from your diaphragm or your stomach. Let's see if we can take a deep breath together and then try talking or phonation. So stimulability based on what was wrong. And again, we have the Swigert resources and the resource from the PowerPoint and resources about how to kind of probe that. So these are the different domain areas. Again, review. If we were in person, it'd be the next time we saw each other and we were going to review from last week, but here we are. Okay, here we go. I again put on, this is in a previous PowerPoint, from Duffy Text, page 363, just in case you wanted to know, some fun facts for you. Looking at some of those deviant characteristics and where we might see them more likely in the different types of dysarthria, bringing us back to that. Here we go, new information finally. So, intelligibility and comprehensibility are a part of every motor speech assessment. They're going to give us some of the most important measures of like communication effectiveness in the real world and outcomes for our treatment. So, I mean, big picture, like fine, here we go. Let's go back to maximum phonation time. We have them say ah for as long as they can and we time that in seconds, fine. And let's say we're working on breast support, fine. But the measure that's going to tell us, 3 weeks, 4 weeks, months into intervention, if the patient's making progress from a humanistic real world perspective, is going to be intelligibility and comprehensibility, because in the real world, who really cares if you can go from 5 seconds of maximum phonation time with ah to 9 seconds after 8 weeks of therapy? Like, who really cares if that doesn't change anything with regards to that patient's ability to communicate with loved ones, friends, co-workers, and improve the communication between the patient and the communication partner. So I know that's common sense, but some of the best markers of progress in intervention is going to be intelligibility and comprehensibility. So every session in therapy, are we checking intelligibility? Of course not. Part of our assessment, we're going to get a measure of intelligibility, which we're talking about now. We'll get an idea of the level and scope of comprehensibility. I'll give you a definition in a few minutes. And then as we're going through interventions in therapy, every so often we're going to get a measure of intelligibility with context and understanding some of those communication strategies through comprehensibility, because numeric data is very important for reimbursement and in our progress notes for patient care. But the value of our therapy isn't going to be down to, wow, 2 more seconds versus last session with our maximum phonation time. That's not really meeting the patient's needs. So these are it seems very common sense, but it's so important for our assessment and kind of our benchmarks in therapeutic interventions. So here we go. So intelligibility, a very basic definition, is the degree to which the acoustic signal is understood by the listener. So we understand that the acoustic signal, the part that we hear, can be affected by compensatory strategies that are implemented by the patient. Sometimes it's hard to parse out if a patient's even using some compensatory strategies. So here's just a visual of the same thing. So here we go. So here we go in this box, patient who has dysarthria, has speech mechanism impairments, has domain deficits in respiration, phonation, resonance, prosody, articulation, or some combination of those. And maybe the patient is already independently utilizing some compensatory strategies. Many patients kind of understand that if they slow their rate down and over-articulate, that sometimes it just improves that output. And then what we take in as a listener is that acoustic signal, and that truly is speech intelligibility. So when we think about this, speech intelligibility is the communication partner's understanding of the acoustic signal. So intelligibility is, so if I'm working with a patient who has dysarthria, myself, I am the rater of that individual's output of their speech output, of how much I understand of that. So the tricky part with intelligibility is that there's many different like definitions or criteria that people might utilize intelligibility. I feel like it's a term that we use for peds and adults, and we kind of just throw that out there. Oh, the patient's 80% intelligible, the patient's 75% intelligible. Well, like, what does that actually mean? And yes, there's standardized motor speech assessments that look at intelligibility, and each standardized assessment looks at intelligibility differently. So remember in the last PowerPoint, there was word level intelligibility and then sentence level intelligibility, and the sentences were predictable and the person who was listening to the message already knew the message. Well, guess what? That's likely going to be skewed by bias of having increased intelligibility, because as I'm assessing this patient using that standardized measure, I already know what the target is. And unfortunately, our brain, we can kind of put the pieces together unintentionally versus just that true acoustic output or the input that's coming in. So let's talk about this a little bit. So when we're talking about intelligibility, we have to kind of think about this with context. So for the speaker's task, there's many ways we can look at this. We can give them a list of single words and they have to read them or repeat them. And then we can kind of do a binary system of yes, we understood, or no, we didn't understand. Well, that's a really structured task and likely an inflated measure of intelligibility. So if I'm having a patient, I give them a list of words and I know the words, and then I'm going plus or minus like a binary system. Yep, understood, didn't understand, understood, that was fine. Great, the patient is 90%, making this up, gave him 10 words, 9 out of 10 times, 90% intelligible at word level, given known context and stimuli, doesn't give me a great understanding of how that data, that number doesn't give me a great correlation to how intelligible that patient is going to be. In conversation with an unknown context with an unfamiliar listener, likely there's going to be a significant discrepancy. And there's no perfect way to do intelligibility, because if you look here, in the best sense possible, we would love to have an unfamiliar listener that's not the SLP judge unintelligibility, and every time we're assessing it from assessment all the way through therapy throughout, we'd use that same unfamiliar person to judge. Well, guess what? In the hospital setting, you can't bring in an unfamiliar listener with you to the patient's room to do this. And even in outpatient and all these other levels of care, you're not going to likely have anyone that's an unfamiliar listener that's going to be able to consistently do that. So unfortunately, the reality is the speech pathologist is likely going to be the person who is going to be judging intelligibility. That's just likely the reality. Now, if you have a caregiver even a caregiver, they're going to know they're already going to be familiar with that person's speech. So unless you're working maybe in like a university clinic where you might be able to kind of have a large sampling of adult individuals that have gone through HIPAA training and have permission to do so to go in the patient's room, it's unlikely that you're going to have anyone but yourself to kind of judge that intelligibility piece. And that's just the reality. So what are some ways we can kind of reduce that bias or get a more authentic sample of intelligibility? So something we can do is utilize unpredictable sentences. So we don't necessarily want them, there's not right or wrong, but some things we might want to try and avoid is to ask them to tell a story or to describe a picture because there might be too much context. So we might, if we give them a picture, just, a picture scene, and we already know the picture, and then we have them describe it, and then we do a plus minus of every word we understand, well, that's still kind of knowing the context that can skew it. Something you could consider trying, I put this as a resource for you. Where is it? Unpredictable sentences. Where are we? Oh, looking for it. Here, McHenry. There it is. McHenry has research. Okay, here we go. Provided like a construct, trying to find some like another modality because there isn't a perfect way of doing this, but trying to kind of reduce that bias and utilizing unpredictable sentences for intelligibility testing. So they put together and feel free to read this, that's fine, great. I'm looking at the appendix. This is what I'm looking for. They put together a list of 50 sentences that are just unpredictable. If the sentences don't really make sense, you can't start the sentence and kind of know where it's headed. So they're just kind of silly sentences. However, if you're having the patient read them out loud, you can't really predict them unless you memorize all 50 sentences. And using these sentences, I have not memorized any of these. So here you go. Here we go. Let's see some of the sentences. Mark buys baby elephants, salty, crunchy cashews. Like that, there's no way I'm going to predict that in sentences. So this might be a resource you might want to use as a clinician or put in your Unit 2 project, that's fine. But if you're in your Unit 2 project, you have to create and take data on intelligibility. And you can't just say, I'm going to have the patient tell me a story and I'm going to measure intelligibility. That provides no context. Like, what am I taking data on? So if you're going to have them read a passage, if you're going to have them look at a picture description task, I'm not saying there's a right or wrong with the way you do it, but the instructions have to be clear as the clinician on what I'm taking data on and providing context because that matters. So utilizing unpredictable sentences might be helpful to do that because it's just you have a robust list of questions or sentences, have the patient read 20, 10 of them, however many you want, and then you can kind of plus minus of those, what are the words you understood? Plus minus Tim, and look at the first one, Tim stated she should leave that date. And then the patient says something, and then you can kind of just take data plus minus, plus minus, plus minus, and then go back. So here we go. Here's one way you could think about intelligibility. You give the patient a list of 10 unpredictable sentences, fine, 10 or 20, doesn't matter, trivial number. And then you as the clinician, you don't have those sentences in front of you. So what you can do then is the person says a sentence and then you write what you think you heard them say. And you do it for all 10 sentences. Then after your session, you would go back and you look at the list they have that you provided them, random list of 10, and then you can check based on the context now and you're taking data, kind of plus minus how many words you understood of that. And then from there, you can add up all of the words you understood, whatever that is. Let's just say it's 70 out of 100 words. Let's just pretend out of all those sentences. And then the minuses is the sum. So the entire amount of words is the sum. And then how many you understood correctly is kind of like, you put that on top. So 70 out of 100, 70%. And then you can say patient was what? 70% intelligible at sentence level given unknown context. That gives more information. It gives better than saying just 70% intelligible or 70% at word level at least you have a little bit more context to kind of guide the severity, because someone that says they're 90% intelligible at word level given known context versus saying 90% intelligible during a structured conversation task given unknown context tells us two different things. So when we have our synchronous portion next, we're going to kind of talk through ways we could maybe troubleshoot or talk about intelligibility. Because when people say, oh, they're 80% intelligible, I go, and give me more. Like, I need to understand more, because that's going to help me understand benchmarks. And guess what? The way you assess intelligibility in your assessment is going to be a similar way you assess intelligibility 6 weeks into therapy, 10 weeks into therapy, etc. So, I mean, I know it's tempting to do a picture description task, but if you do that, then you have to do a very similar kind of task every time you're benchmarking. So sometimes using unpredictable sentences may be a more efficient way, reducing some of that bias when we are taking in that auditory input. Again, nothing's going to be perfect with this. It's just not going to happen. All right, so things we need to consider: live in the same room versus audio tape. We would love to say we would like to do this live in the same room. That would be helpful. Maybe. There's not like a right or wrong with this. Like, it's difficult because when we're doing intelligibility, we really should be kind of just taking in that auditory input, right? Like what's coming in from the patient's speech output. However, we can also, that speech out, what we're listening to can be impacted by other cues that are not just that auditory signal. So gestures, body language, miming, all of these other things that I'm doing to distract you as you're watching this video, here we go, can inflate that percentage. So when you're in the most authentic way, which is not the reality of the real world, when you're taking intelligibility, you want to kind of take away all those other pieces. So if you're doing unpredictable sentences, for example, consider just listening and not looking at the patient's all of those other factors, because we're going to look at comprehensibility, which uses all those factors in another way. So if you're live in the room with the patient, we have to be mindful that looking at their face, body language, gestures may inflate the percentage. So think about only kind of listening to that auditory signal if it's an audio tape. But again, there's going to be a lot of other variables that kind of happen. And then consider who's judging the task. Even if we're kind of using unpredictable sentences, etc., we as speech pathologists intuitively are going to kind of put those pieces together. So just be careful. So the most basic way of doing this is the percentage of intelligible words out of the total words, and you provide that percentage. And don't just provide the percentage, provide the raw data too. So it's just like if you're reading a research article and if they said 90% of people, 90% of speech pathologists agree with this statement. Well, if it's only 9 out of 10 people, that doesn't give a lot of weight compared to 900 out of 1,000 speech pathologists. So if you're putting intelligibility in with regards to any data, even when I'm supervising an 8200 or with any other clinical experience, always put the raw data with the percentage. So if you're saying the patient's 90% intelligible at sentence level with unpredictable sentences and unknown context to unfamiliar listener, put 90% and then put in there 9 out of 10 utterances or words. Provide that context. Fine. Sorry, I get really passionate about intelligibility because I feel like people just throw that term around, and it's a really important term that we use for motor speech and dysarthria, and I want to make sure that we provide the value that it should have for intelligibility. Okay, so here's some resources related to intelligibility. I already gave you the McHenry one, those unpredictable sentences. Some published tools related to intelligibility out there. They're out there, but again, single words, sentence level. Sometimes they're kind of predictable, predictable sentences. So I just put those out there for you if you want them. Don't know if they'll be super helpful. Okay, So we talked about intelligibility. We're going to have a conversation when we meet next time. Comprehensibility now is communication effectiveness. So the degree to which an utterance is understood given all of the normal communication context. So when we're communicating, of course, in the real world, unless we're on the phone. Well, who uses a phone anymore for like phone calls? But in general, what are all of those other like overlaid principles or supports that help with getting that communication, that message across? Whether that's gestures, facial expressions, lip movements, prosody, all of those other pieces to help, okay, get that message across, providing topic maintenance, contextual information, all of those other things that we utilize, sort of like what we do for oral rehab. So when we're talking about some of those oral rehab strategies, working with individuals who may be in the deaf or hard of hearing community, we talk about some of those communication breakdown strategies, appropriate lighting, reducing background noise, providing context, asking questions, like all of those things that we use to kind of get that communication effective across, regardless of population. That's what we're talking about with comprehensibility, because there are patients you'll work with who might have, they might be only 50% intelligible, just by the acoustic message. However, guess what? When they use their AAC device and they utilize slowing down their rate and gestures and their communication board, guess what? Now they're 80% with all of these supports. So we need to kind of take that acoustic piece, that message with intelligibility, and get some information about comprehensibility and communication effectiveness, because many patients, we might be working on each deviant domain area, fine, if it's stimulable, and regardless of domain area, we might still be working on a communication effectiveness, because likely there's going to be communication breakdowns. And some people are great at kind of intuitively kind of scaffolding and supporting those breakdowns, and some are not. And sometimes communication effectiveness, we're working with the patient on their skills, but also some of their communication partners and helping them troubleshoot as well. Oh, right. Okay, so here are some factors that can affect comprehensibility. Physical environment, think oral rehab, like I just said, amount of background noise, traffic, TVs on, the degree to which a patient or the people can see each other's face. Looking at someone's face can kind of help sometimes with that message. Think from the speaker perspective. Providing syntactic content. Increasing predictable sentences and structures, noun, verb, object. We work a lot with individuals who have aphasia with some of this. We can utilize some of this for dysarthria as well. Helps with comprehensibility. Looking at giving a topic before talking about it, smaller sentences, utilizing gestures. Adding gestures just in general can help gain 70% of the message, right? You could just maybe you already muted me. We wouldn't know. But if you muted me right now, I could probably get some information to you regardless of if you could hear me at this point. Orthographic cues, writing occasionally, writing the first word, using an alphabet board, all of these different, slowing down the speaker's rate, which I'm not doing, I'm talking very fast. All of these things can affect comprehensibility. You see, this is exciting to me because this is like intervention. This is what we do with our patients. We actually impact their communication exchanges with people. Things we can kind of work on or examine. Listeners, looking at the speaker, paying attention, giving feedback instead of just saying, what? Huh? That doesn't help. We know that. Breakdowns and repairs. Things we can notice. Sometimes what we'll do, not necessarily in the first evaluation, more outpatient. Sometimes when we're kind of getting to that like caregiver family education piece and that buy-in with home exercise, like interventions. Sometimes just watching the interaction between like husband and wife, partner and partner, caregiver and partner, whoever it may be, we can kind of without even like just watching, we can see how often is there a breakdown? Are they attempting to repair it? Is it successful? Are they even identifying that there's a breakdown? Some of our patients might have other deficits related to just motor speech. They might have some cognitive or attention or executive function deficits, whatever it may be. So we can see from the patient and communication partner, what are they doing or not doing or identifying to kind of repair that message? Fine. Even neurodegenerative populations. This patient likely is going to have dysarthria and it's going to get worse. We're not going to necessarily dramatically change that output, but what can we do to compensate or repair because we're going to have communication breakdowns? Okay, see, I'm getting very excited. Totally fine. I'm going to, let me pull this up first. See, you got me going now. So here we go. Nope, that's not it. I have, wow, it's a lot of things open. So Dr. Strand, Edith Strand, big in the world of childhood apraxia of speech and acquired. Let's pull up her resource. It's thinking. My computer's very tired. Here we go. So this is kind of adapted from her resource. Kind of tweaked it a little bit. That's fine. Dr. Strand's resource. But I like structure, but instead of just thinking of this like elusive communication effectiveness, like which is just kind of this like concept, what are some concrete things we can look for within our patient or the communication partners to kind of like make measurable goals and thinking about how to target communication effectiveness or comprehensibility. So here we go, like look at this. Like they're verbal. So here we go. Initiates attempts to communicate, verbal. No conditions when verbal is successful or not, answering questions and that. Are they like when are they successful, when are they not? If they're unsuccessful, how are they attempting to make repairs? And was that communication repair successful? What are they doing besides just speaking? All of us can do this, not just people who have dysarthria. Are they using gestures? Are they using any symbolic representation? Are they using writing? Are they using AAC? Are they using a communication board? And if they're using it, are they using it successfully or not? I worked with a gentleman, maybe only a couple of years ago. Individual had Parkinson's and concomitant dementia and had significant hypokinetic dysarthria. And he had this elaborate, wonderful, dynamic AAC device, like top of the line, wonderful device. And he could identify when there was sometimes like a communication breakdown with his wife. I remember this. However, he never once utilized his communication board to maybe find the symbol or to use the, type out what he was saying. So he had some of these resources, but wasn't using them effectively. So guess what? Our interventions not only worked in vocal intensity and some of these other like Lee Silverman voice therapy interventions, we worked on utilizing his device because his voice is rapidly, his speech intelligibility was rapidly declining and kind of his clinical presentation was likely to continue to decline, utilizing his resources effectively, just giving some a communication board or saying, just write the first letter of the first thing of what you're trying to say, or write the topic before telling someone. Using it versus knowing it is two different things. So these are things we might want to work on. And the other behaviors we might want to look at. Give the context, get the listener's attention before speaking to them. I feel like I could do that at home. Sometimes I'm like, as you might know in my videos, I might shout, into another room, but not getting their attention. So I'm making a breakdown. Like right now, my husband's in the other room. If I go yell at him, hey, Arthur, see, he didn't even hear me, or he's ignoring me, whatever. But we have to like get the listener's attention maybe before communicating, making sure they're engaged in the conversation, looking at our face, using some of these environmental strategies or resources in order to hopefully maximize that comprehensibility. It's not changing their intelligibility, but their comprehensibility. Wow, multisyllabic words are challenging. And then looking at the listener, what are they doing to kind of alleviate or facilitate some of these communication breakdowns? I'm so guilty of this. Like if I don't understand what someone says sometimes, like if I'm at home or someone, what'd you say? Well, that's not a super effective strategy. I thought you were talking about this. Am I correct? Providing some context, even from the listener's behaviors perspective. So I like this resource because it gives structure on looking at it's kind of like an observation of a patient, looking at them contextually about what they're doing from the speaker's behavior to kind of hopefully compensate and work on comprehensibility, what's successful or not, or lack thereof. I've seen patients that don't maybe utilize many of these strategies. And then from the other perspective, what are the communication partners, they're the listeners, the people they're talking to day in and day out, not just us 1 hour a week. What are they doing to help facilitate this? Because it's a partnership between both. Okay, so from there, you can see that's a nice resource. It's something I've used with real patients and outpatient. It's a nice guide for structure. So if that helps you as a resource in the future, that's wonderful. Adapted from Dr. Strand. Didn't create this independently. Have to give her credit for that. Something to consider. Do you want to put it in your resource guide? I mean, you don't have to. No, it's not like a part of the rubric of what you need, but if that's something that might be help you in the future, feel free, or just keep this resource. Okay, so that really brings us to the end of the assessment. You know, a motor speech assessment isn't this long, robust assessment where, like I have for Unit 2 project, we look at those specific areas. We do motor speech, we do SMRs, AMRs, we are going to stress test, we're going to do stimmability, assess all 5 domain areas, do a connected speech sample, get some intelligibility information, any information on comprehensibility. We do we do our stimmability, we kind of figure out and get some information about the patient's perception, etc. Again, this is a poor summary. However, we put all that together, and by the time we're done with our assessment, the goal is we understand type of dysarthria, deviant speech characteristics, ones that we think are stimulable, and from there, ones that we think we can really shape and will impact communication effectiveness and comprehensibility. And then we kind of go from there based on neurodiagnosis, etiology, and evidence on shaping our therapy. Because I think the assessment piece and therapy go hand in hand. If you provide a superficial, inadequate, incomplete assessment, your therapy is going to be incomplete, because if you don't appreciate those patients' areas of strength and areas that need remediation and can be shaped, and understand that patient perspective, we're not going to provide really robust, efficient interventions. It's just not going to happen. So I have a video here. Last thing, or maybe not. Let's see if I can pull it up. I'm gonna pull it up. I'm gonna pause for a second. I'm gonna pull up a video. It's like a 2-minute video, and it has 2 individuals. It's here. I'll just pull it up and then I'll give you a summary. Okay, so we're gonna watch a video. It's a very brief video, less than 3 minutes. It's looking at intelligibility and compensatory strategies for the patient. So it's gonna be a sentence level intelligibility task. This patient has pretty marked dysarthria. And then utilizing some compensatory or comprehensibility strategies. Now, the reality is, when a patient has really profound dysarthria, or even unpredictable sentences, it can be super challenging. Let's just watch it, and then we'll kind of unpack this. So here we go. Let me just play it.
Okay.
There you go.
All right. So, number 5.
Okay.
Okay. Number 6.
But I need to be fit.
Okay. Number 7.
As I'm a few weeks later.
Number 8.
There's no benefit in nursing.
Okay. Number 9.
I hope you have enough time and energy to spare.
Number 10.
Is with me and allowed to continue.
Okay. Sentence number 1.
They had a one and noise.
Sentence number 2.
One is but
Sentence number 3.
The dog laid with a stick.
Sentence number 4.
The fox does do it.
Sentence number 1.
The little boy left home.
Sentence number 2.
They're going out tonight.
Sentence number 3.
The cat jumped over the fence.
Sentence number 4.
He wore a yellow shirt.
So that video, it's old, I understand that. And it's literally a video, me taking a video, which is another story in and of itself, totally fine. However, okay, so this individual has pretty profound mixed dysarthria, and we're not differential diagnosis, but clearly has some spastic tendencies. But however, intelligibility is negatively impacted by negatively impacted. It's difficult to understand him just by the acoustic signal. So if you want to go back and watch these 2.5 minutes, you note that he says the sentence, and then right afterwards it kind of pops up on the screen what the target was supposed to be. And then from there, you can see they attempted different strategies to kind of see if it would change the message for sentence level. So the first letter of each word, talking about the topic, and if that impacted it. So this is kind of an example of looking at intelligibility at the sentence level with unknown context for us, and how difficult it was to really understand his output. And then looking at, did it change or how much when utilizing some of these compensatory strategies, and thinking about moving forward, which strategies do you think were helpful? What would we do with this patient? And does the patient have buy-in to use these? We could give these strategies, and if the patient's not going to use these with anyone but us once a week, that's not helpful either. So I just wanted to end with a real patient video about comprehensibility and intelligibility. So we're going to move into Unit 3, talking about now, we know the type of dysarthria. We kind of understand the different domain areas, the deviant speech characteristics and stimulability, and now talking about looking at what can we do from a behavioral kind of speech perspective to shape those different domain areas if possible based on evidence. And then if not, or in conjunction with medical, prosthetic, and other areas and medication, pharmacological, what does it look like for our patients? And that's Unit 3 before going into apraxia of speech. So I'm going to conclude there. And we'll talk about intelligibility and comprehensibility as well, likely before you even watch this lecture, because it's going to come up in our next synchronous portion.